Now, a couple of other important points to make about cardiac arrest more generally. It's a massive public health problem. It's actually the leading cause of death in the developed world. Hundreds of thousands of Americans each year suffer a cardiac arrest. The number is not very precisely known, but we estimate at least 300,000 Americans each year suffer cardiac arrest. Most victims of cardiac arrest die before even reaching the hospital. So this is very lethal, and very lethal within minutes of suffering cardiac arrest. Indeed, less than 10% of patients actually leave the hospital alive after a cardiac arrest. Now, this number is changing, and one of the purposes of this lecture series is to share with you some of the exciting things that are changing to improve survival. It's not as lethal as it once was. Nonetheless, most people die who have a cardiac arrest. Another very important concept to get across, especially for the healthcare providers listening to this lecture, is that cardiac arrest commonly strikes people in their 50s and 60s. So this is generally healthy people, and it strikes with few warning signs or symptoms. I think many healthcare providers have a bias. We often think that cardiac arrest victims are elderly, people in their 80s, 90s, or older, people with very advanced disease. In fact, that is not who commonly gets cardiac arrest. And by definition, by the way, cardiac arrest is the sudden and abrupt stoppage of the heart. You could argue that technically we all die of cardiac arrest because by definition the heart stops in death. But what we're talking about here is sudden electrical storm of the heart causing collapse, and it's generally people in good health. And we'll return to this when I give you some important examples of famous and prominent people who have had cardiac arrest that you have heard of. Now, one of the things that should both be worrisome and a note of some optimism is that survival from cardiac arrest very much depends on where you live. There's been a number of studies looking at this, but one of the largest and arguably best studies on this in a population fashion was done in 2008. And what this study did was look at cardiac arrest survival in a number of U.S. cities. And what they found was your chance of leaving the hospital alive completely depended on the city in which you had cardiac arrest. This variability in survival, and you can see just how variable it is across these cities, suggests two things. One, that in many cities cardiac arrest survival is worrisomely low, that there are problems. But two, that if we adopted the approaches of the cities with higher cardiac arrest survival, we could save thousands of lives each year from cardiac arrest. And that is food for thought about how we can improve our care, and much of this lecture series will devote itself to thinking through some of these ways to improve care for cardiac arrest victims. Why is cardiac arrest survival so variable? Well, first you should recognize that cardiac arrest survival depends on the performance of something called the chain of survival. This is the fundamental component of many of the courses that teach CPR, and there are links in this chain of survival. And these links include recognition of cardiac arrest and early access to emergency services. What that means really is if you see someone collapse, call 911 right away to get help. Another link in the chain of survival is the prompt delivery of CPR. If you see someone collapse and they're not breathing and not moving, they need CPR. In addition, another link is the prompt delivery of defibrillation, so the use of defibrillators to shock someone, and we'll talk more about when and how to use them. Finally, early advanced care delivery. So the sort of things that ACLS providers do, there are certain medications and other therapies, and we'll talk about that more when we talk about post-arrest care. So these are the links in the chain of survival. An important point to keep in mind, and this may explain the data I showed you on the last slide, is that not all communities have the same strengths in this chain. For example, communities have variable rates of bystander CPR. That is, some communities, many people in the lay public know CPR, others, that is less so. In some communities, there are defibrillators on the walls in every gym, in every mall, and every airport. In some communities, there are no defibrillators to be found, and so on and so forth. So these variabilities in the links of the chain of survival lead to variable survival itself. Now, one of the key things that I think we have to keep in mind is that public knowledge plays an important role. Public knowledge about CPR and the willingness to perform CPR varies from community to community. As I had mentioned, there are these devices called AEDs, or automatic external defibrillators. Now, they are everywhere these days. You've seen them in airports and train stations. You may have wondered what they are. Indeed, They are very variable in their placement and availability, and it worries me every time I go to some large public venue that does not have AEDs. This is becoming less common in the year 2012, but still, they are variously available, and these devices are lifesavers. Another important aspect about survival variability is the quality of paramedic response. And when I say paramedic, that's the term most of us commonly know. What we really mean is emergency medical services, or EMS. Those are the whole range of healthcare providers who drive in ambulances and respond to emergencies. The responses can be very variable. Issues of traffic and response time, issues of staffing and experience. Some communities only have volunteer EMS groups, whereas some have full-time paid professionals. Sometimes the volunteers are as good as the paid professionals, and sometimes paid professionals are understaffed or undertrained. So it's a very complex topic with a lot of variability. Now, it turns out there's also variable public knowledge about AEDs, those very things that are in train stations and airports and other places. And indeed, there was a study, a very interesting study, done in a train station in Europe in 2011 that was a very simple survey study that asked members of the public walking through the train station, people who walk by an AED every day of their life while they were on their way to work, and said, do you know what this device is? Do you know about AEDs? And what they found was most people did not know what an AED was. Most people could not describe how you use an AED when told what it was. And the minority of people actually knew that members of the public could use them. Most people felt that they were only there for healthcare professionals. Now, it's interesting to note that if you asked most people about fire extinguishers, they would immediately acknowledge that it's there for anyone to use if there's a fire. So somehow the fire extinguisher has entered our consciousness. The AED has not yet entered the public's consciousness. And this is important because in many cases it's the lay provider who's first on the scene who could save a life with that defibrillator. So it raises an important question. If someone collapsed from cardiac arrest in your train station, would people know how to grab an AED and use it? Is one available? Perhaps I should assign this as a homework problem. You should go to your local train station, mall, health club, and look and see, is there an AED on the wall? And if not, you should ask why not. Now, I want to share with you some of the exciting things that are improving survival. It's not just AEDs and better CPR. There's a concept called dispatch-assisted CPR that's very important. And you see here a dispatcher sitting before a computer screen in an emergency response headquarters. If someone calls 911 in some communities and they don't know how to do CPR and they don't know how to use an AED, the dispatcher can coach them on the spot in real time, meaning the dispatcher has a script where they talk through the required actions of CPR. It's been a remarkable innovation that has really improved survival in some communities. And this has been a growing concept being used in more and more cities throughout our nation. And indeed, a recent publication looking at this and looking at the use of dispatch CPR instructions found that this was so valuable that it encouraged their use across communities in the U.S. And I want to share with you a simple algorithm that is used when we think about dispatch-assisted CPR. So you call 911, the dispatcher will ask, is the patient conscious? If they're not conscious, the next question is the patient breathing normally? And if the person on the phone with the victim says, no, they don't appear to be breathing normally, CPR instructions are given. So that sort of forms a backbone of what we think of as dispatch-assisted CPR. And as I said, in many communities in the U.S., this is greatly improving survival from cardiac arrest. I want to share with you another really important concept around cardiac arrest, which is the time sensitivity of this illness. What do I mean by that? Well, the second you go into cardiac arrest, a stopwatch starts, and that stopwatch is really the chance of survival. The chance of survival plummets with every second, with every minute you're in cardiac arrest. This is a typical survival curve, a schematic and illustration, not actual data, but showing you approximately what happens. That the second you go into cardiac arrest, your chance of surviving falls, and by around 10 minutes of untreated cardiac arrest, your chance of survival is about 10 to 15%. And that's in a good community with good response. So this is a real problem. It's a real problem because if you think about it, in city traffic, it may take 10 minutes for an ambulance to get to a victim of cardiac arrest. One of the key things that's important for all of us, lay public and healthcare providers together, to recognize is the early delivery of CPR changes this curve. if a person in the public or a healthcare provider happens to be in the public nearby, a victim of cardiac arrest, if CPR is provided on scene within minutes, the chance of survival changes dramatically. And you can see here what happens. It can double to even triple the chance of survival. That's why lay public CPR is so important. And there have been a number of studies looking at this. In some studies, survival is increased by twofold, and some more than twofold, but it's a big change in survival with the provision of layperson CPR. So the bottom line is public CPR matters, and if you're watching this as a member of the lay public, an important take-home lesson is you should learn CPR and your family should learn CPR. Now, one of the problems with CPR training that I want to spend a minute or two on is, where do people learn CPR? Well, a lot of people learn CPR in schools, so we train young people. You might learn it in high school, or you might learn it in college as part of a school program. I might ask you, if you're a person in your 20s listening to this, how many cardiac arrests have you seen in the public when you're walking down the street or in an airport? Very few, I would wager, hopefully none. So if you think about it, there's different categories of ways we could train people. What we often do is train people in schools. The problem with schools is these are people at low risk of seeing cardiac arrest. In other words, 20-year-olds are not usually around 50 and 60-year-olds with coronary disease, except perhaps for their parents when they're teenagers. The people who are around people at risk for coronary disease and cardiac arrest are people in their 50s and 60s who are not in high school and college. Now, there are other ways we could think about training. We could train in a senior center where people are elderly. They're certainly at high risk. The problem is that may be difficult, and there may be low motivation in senior centers to actually learn CPR or train in CPR. One area that we've been exploring is using the hospital as a vehicle to train CPR. When patients are admitted with a coronary disease problem like a heart attack or with chest pain, we try to train the family members in CPR before the patient goes home. To avoid these problems with the school and health fairs, where another vehicle for training, where basically we worry that we're training people at low risk. There are a lot of barriers to training in CPR that also come into play. There are logistics. If you were to seek CPR training on your own, you'd have to find a class. That may be difficult. You also may not like the idea of learning mouth-to-mouth or doing mouth-to-mouth, especially if there was a stranger collapsed on the street. There are other barriers to learning CPR. Many people fear liability. They say, gosh, if I did CPR, could I get in trouble or could I get sued? Now, it turns out there are Good Samaritan laws in the vast majority of states protecting anybody for trying CPR even if you aren't certified. But the public is not so aware of that. So help me spread the word. You are at very, very, very little risk of liability, and in many states, indeed, you are at no risk of liability. Another concern we have, this is less a barrier to training, but a concern with CPR training among people who do get trained, is that CPR skills deteriorate. If you don't practice, you may lose those skills over time.